Good morning, everybody. Thank you very much for coming today. It's very delightful for us to see this conference that has been organized by the Iraqi Australasian Medical Association. A lot of the faces we see here today are actually our community leaders of the profession and all around Australia. So it's such a great pleasure to have everyone here today. I'd like to start by acknowledging the custodians of the land, the Aboriginal people and First Nations of Australia, and we pay our respects to their elders, past, present, and into the future. And we would like to also thank the Macquarie University Hospital for this partnership to make this happen today. Also, we recognize the sponsors, Hologic, Douglas Pathology, and Osteointegration International for their sponsorship of the event today. We also thank the accreditation that was given by RACGP and the 6 CPD points that goes towards the GPs who were recognized today. If you are a GP and you would like that to be, the accreditation forms is available in the registration desk at the front. Just some house rules. If we had an emergency exit, then please proceed to the parking, which is just behind the building there. If we need any toilets, then we have toilets at the other side of the same floor, or there are more toilets downstairs. And if anyone needs disability access, there is a lift that needs someone to help you to get into. Can I ask everyone please to turn off your mobile phones or put it on silent? Thank you very much for that reminder. It's very important to mind as well. And can I now welcome Associate Professor Ahmed Al-Rubai, the Secretary of the Association, to give his remarks.
Good morning. It's really refreshing to have all this number of colleagues to a medical conference on such a lovely Saturday in the post-corona era. I would like to welcome you all to our medical conference. Special welcome to our colleagues from interstate, particularly from Victoria. The conference is a continuation of series of medical conference. We were arranging under the title of Medical Committee in the Iraqi University Graduate Forum for several years. I think we got 7 of the annual medical conferences in a different setting from currently up until Corona era. And this is a continuation, but under the title of the Iraqi Australasian Medical Association. And this would be the first conference under this title. We called this conference the International Medical Conference in a first attempt to have a conference which is open to colleagues from outside Australia. We have an impressive response to the initial ad, to the extent that we deactivated the link for registration from overseas, from our colleagues overseas, because the number was big enough that the whole function room might be occupied by them. And we were worried that there would be no spot for them. Then we realized that getting a visa to Australia is something difficult, even compared with the European country. So none of them managed to get a visa to this conference. The conference is designed to accommodate the needs of our general practitioners, colleagues, and hospital trainees on the line of updated knowledge and practice in 3 main fields, which includes common gynecological disorders, common orthopedic disorders, and the management of obesity and overweight from all aspects through presentation by experienced specialists. All of them are Iraqi, by the way, and all of them are members of our organization. This conference wouldn't be possible without the great effort of a very dedicated team, which includes 12 and now 13 of our colleagues who are presenting today, and you will meet them throughout the sessions. The conference management committee, which includes our colleagues Dr. Basim Al-Ansari, Dr. Artin Arzidian, Dr. Alia Al-Alusi, Dr. Media Elias, Dr. Hussein Sinid, Dr. Bushra Al-Ubaidi, and Dr. Mustafa Rida. I would like to thank them all. Thanks and appreciation are extended to Macquarie University for its support, with a special thanks to Bernadette Robinson and Lara Watling for their great help in the RACGP accreditation for the conference and for the purpose of the CPD points. I would like to thank our sponsors, Douglas Henley Moyles and Hologic and Osseointegration International. I wish you a fruitful and enjoyable time today. Thank you.
So we will start our first session, which is common gynecological problems, and we will have Dr. Batul Nadim as the moderator, and she will be presenting. She will introduce the presenters, and she will introduce their bios one by one. She comes with more than 25 years experience in her field with subspecialty in ONG ultrasound, and she's very well recognized name in the profession. So welcome her.
Thank you very much for the lovely intro. Sabah al-khair, assalamu alaikum, good morning. I have the privilege to present the first session of today's gathering, which is the gynecological session. I hope it will be informative to all of you. Our first speaker for today is Dr. Jumana Faraj. She's
Farjo.
Farjo. Dr. Farjo is a graduate from Baghdad Medical University in the year 1995. She completed her specialist obstetrics and gynecology training at Liverpool Hospital and the Royal Hospital of Women in 2011. For her advanced training, she undertook a fellowship in endoscopic gynecology and in medical imaging. She is currently staff specialist at Royal Hospital for Women, working in both gynecology and medical imaging department. She is also a VMO at Prince of Wales Private and North Shore Private Hospitals. Dr. Farjo had a special interest in endoscopic and robotic surgery, and she's part of pelvic floor and urogynecology unit at Royal Hospital for Women, as well as the benign gynecology services. She also has a great interest in outpatient hysteroscopy, and in particular the case of diode laser in outpatient clinic, and has worked on establishing that service in the hospital in the last 6 years. Dr. Farjo is also a training supervisor for the College of ONG and is regularly involved in teaching and research on the medical student University of New South Wales. Now, Dr. Farjo is going to present to us the abnormal uterine bleeding. Thank you very much.
Good morning, everyone. Thank you, Dr. Nadim, for the introduction, and thank you for the Iraqi Australasian Medical Association for organizing this diverse meeting. I was initially was asked to be the moderator for this session, but due to sort of last-minute change of the meeting plans, I became a presenter. So I was within a short notice asked to give this talk, and I chose the abnormal uterine bleeding as it has a quite great relevance to both GPs and specialists. The main focus of this talk will be on the clinical care standards that has been produced or published by the Australian Commission on safety and equality in healthcare that was published in 2017. So, am I correct or I closed it? So abnormal uterine bleeding happen in women in different stages in their life. It can happen in the premenopausal stage as well as the postmenopausal stage. And the types of bleeding that can happen in the premenopausal women is ranging from intermenstrual bleeding, postcoital bleeding, to a heavy menstrual bleeding that I will be focusing on today. So heavy menstrual bleeding is it's a quite common problem in women in their reproductive age group. It happens in about 25% of women. Is usually associated with quite sort of disabling or affecting their quality of life. So a menstrual cycle is a quite personal experience for most women, and it's really hard to compare or define that sort of problem for most women. A lot of women consider it as a normal sort of thing that they have just to carry on with. In definition, the heavy menstrual bleeding is a blood loss of more than 70 to 80 ml per cycle, but that's really, as I said, hard to define. So we assess it or gauge it based on the effect on their quality of life. It can also be associated with abdominal pain or dysmenorrhea, which can happen in 50% of women with heavy period, and this also have an impact on their quality of life. A heavy bleed can lead to iron deficiency anemia, which can affect the women's general well-being. So the causes are diverse, and the FIGO classification system using the palm coin definition, which is like structural, dividing it into structural and non-structural causes. So for structural causes, you have the discrete pathology that can be found on ultrasound or diagnosed on histopathology, and things like an endometrial polyp or fibroid, malignancy or hyperplasia. And then you have the non-structural causes, which are harder to identify on imaging, and these are things like coagulopathy, ovulatory dysfunction, endometrial pathology, and iatrogenic causes. Very important to when counsel the patient, to explain to them that often there's more than one pathology at one time. So removing a polyp or resecting a fibroid will not solve their problem, and different modalities of treatment should be considered. So the national or the clinical care standards, which is produced by the Australian Commission on Safety and Quality in Healthcare, were introduced because they identified in that review that there was a quite significant inequality in the healthcare provided to women in different regions in Australia. And the aim of these clinical standards is to provide the least invasive, most effective form of treatment, considering the women's choice and their desire for fertility. The Commission found that we still do more hysterectomies than compared to other sort of developed countries around us, like New Zealand or the UK. And there is also a quite significant variation between the mode of treatment that's offered to women in different regions in Australia. So they found that there was a 6.6-fold increase in the rate of hysterectomy in regional areas compared to cities or remote country. And then there is also significant increase in the endometrial ablation rate in cities compared to regional and rural countries. So they published 8 standards of care sort of recommendations, and I'll take you through them individually. So the first one focuses on proper assessment and diagnosis. So very important in any sort of patient assessment is the history and obtaining the right information, and there's a quite sort of standardized questionnaire we ask the patient about their menstrual history. As I said before, it's assessed based on the effect of the bleeding on their quality of life and if they have any other associated symptoms. The symptoms related to the non-structural causes like the bleeding disorder, polycystic ovarian syndrome, and thyroid disease should be addressed. Risk factors for endometrial cancers should be assessed, especially by the GP colleagues, because you will want to have these patients looked at and investigated sort of promptly. So women with high risk factor for endometrial cancers, like women with polycystic ovarian syndrome, obese patient, diabetic, people on tamoxifen, are all at high risk, and these women will require prompt investigation, and also the type of treatment that can be offered to them has to be more definitive treatment. You want to stay away from like sort of ablating the endometrium, which then make it harder for them in the future to be diagnosed if they would have developed malignancy. Cervical screening history is very important, and like sort of abnormal pap smears and cervical cancer can present with abnormal bleeding. And then you want to understand their sort of sexual and reproductive story and their future desire for fertility to gauge and decide what sort of treatment you will offer these patients. Physical examination and investigations are very important, so focusing on like sort of basics, general appearance and vital signs, abdominal examination, palpate for big fibroids and bulky uteruses, bimanual vaginal examination, and the cervical screening. Always with women with bleeding and any women with sort of reproductive age group, you have to exclude pregnancy. And then look for iron deficiency anemia, and organize all the other relevant blood tests to rule out any non-structural causes. And then we will focus on pelvic ultrasound later when we address one of the other standards. So informed choice and shared decision making is one of the statements that they produced. And the aim is to try to engage these women in the decision making regarding the choice of treatment. It's not always they have like sort of to tell them that you have to have a hysterectomy or you have to have this option. You have to offer all options, and they have to choose from these options. When you do that, you have to focus on what risks and complications involved with each procedures, and what are the success rates in each of these procedures. You have to consider all sort of cultural and religious factors and their desire for future fertility. A lot of women that walk into our rooms have misinformation about what treatment they are going to undergo. So they already have a preformed ideas, and that comes from different sources. It can come from Dr. Google, and I put this picture of women chatting because that's the most common thing. They come and tell me that my mom, my friend, my sister, whoever, not considering the big picture and not considering individual patients. The first most important thing is to discuss these misinformation and try to rectify it. So the next quality statement was about initiating the treatment, and that comes from the GP colleagues. So initial treatment is always medical. And while we're waiting for further investigation, we can always do something about the heavy period. So this sort of type of treatment will depend on what sort of problem these women are having. So if they have irregular heavy period, if they have painful period, if they desire contraception, and also you have to discuss the side effect and the success rate of each of them. So the most common pharmacological options are either non-hormonal, which is like non-steroidal anti-inflammatory drugs, and they are quite helpful if the women also have dysmenorrhea, but they can reduce the heaviness of the period by about 20%. If you combine it with tranexamic acid, that's about 40 to 60% reduction in the heaviness of the bleeding. The hormonal options, and the most common one, is the long-acting IUD or Mirena, and there's a sort of a baby version of it called Kyleena. And then you have the combined oral contraceptive pill or the progesterone-only pills, and they are not commonly used to treat menorrhagia, but there is a new type of progesterone-only pill called Slinda, which has been quite helpful as well. Then you can use cyclical progesterone, and as gynecologists we prefer Provera, but a lot of GP colleagues like Primlu. Then you can also offer the injectable long-acting progesterone like Depo-Provera, but they have You can't use it for extended period of time. You sort of try to minimize it to a short period of 1 to 2 years to reduce the risk of osteoporosis. This is a topic that that statement I like because I trained in ultrasound, and quality imaging is quite important in all aspects of gynecology. So it is done to investigate for structural causes and to exclude malignancy. It ideally should be done between day 5 to 10 of the cycle to obtain sort of a thinner endometrium, and you can then identify pathology easier. And you assess for all different aspects of the endometrial thickness, appearance, vascularity, polyps, fibroids, and also for things like adenomyosis and adenomyoma. So this is a picture of a woman in her 30s with menorrhagia. The scan done, and it was reported as normal. But two important things I would like to look at that image and understand is where is this woman in her cycle, and if this was done in the second half of her cycle, probably that's a normal endometrium. But if it was done straight after period, that's a thickened endometrium. Also, I would like to put color Doppler on this image to see if there was any vascularity within the endometrium. The same patient, if you put a bit of saline in and you do a procedure called a sonohistogram and you put color Doppler, you will find that it was not a normal endometrium, and it had polyps and it had blood flow in it. The fifth one statement is about the use of IUD, and this is quite important because IUD or Mirena IUD are a game changer in gynecology. It sort of changed gynecology a lot because it's not only a contraceptive, but also it being used for all sort of reasons like menorrhagia, dysmenorrhea, and all other reasons. So it can be used for all women in all age group, regardless of their parity. It can be put in an outpatient or in theater. You sort of, any women in the reproductive age group, you want to screen them for STI, and you have to talk to the women about side effects. And the most common thing is the bleeding and the pain that happen after the insertion, which can last a few days, few weeks, few months, but it will eventually settle down. We often ask women to wait for 3 to 6 months to assess how well they do with it. It depends also on the size and the shape of the uterus. So if you have a big uterus, it might not be suitable. If you have a septum or a bicornuate uterus, it might not be suitable. The sixth quality statement is about specialist referral. So when to refer if you're concerned about malignancy, and if you have pathology identified on ultrasound, and when you failed medical treatment for 6 months. So there is all these other alternative treatments that we can offer women. So this is a polyp, and the polyps are quite common. There's all sorts of reasons why they happen. They are rarely malignant. They're most commonly benign. And we treat them because if they present, mostly they're asymptomatic, but if they are big enough, more than 1 centimeter, if they're multiple, and if they're giving symptoms, we treat them. This is a picture of polyps. And fibroids are most common pelvic tumors, and they're quite common in women. Again, they're mostly asymptomatic. And there is a classification system for fibroids, depending on where they are in relation to the uterus. And there's all sort of risk factors for it. If they were symptomatic, the most common symptoms they give is heavy period. They also can give bulk or mass effect pressure on the pelvis, bladder, or bowel problem, and they can impact fertility depending on where they are located. Again, all this assessment, ultrasound, sonohistogram, looking inside the uterus, doing a hysteroscopy, and MRI if you are planning sort of complex intervention surgery.
1 minute.
Sorry. So hysteroscopy for removal, all different options. This is MyoSure, because Hologic is sponsoring the talk. So MyoSure is a morcellator. So it's used to, mainly I personally prefer using it for a large bulky intracavitary fibroids, and it sort of chips it in small pieces and suck it out. Then you have the laser, which I sort of use a lot in outpatients, and it has its own advantages and limitations. And this is the laser. So it cuts and burns at the same time. And it can pass through a very small scope. It has its own benefit. Then you have all other different fibroids that's in the wall or outside the wall. It can be managed surgically, laparoscopically, robotically, whatever people prefer. Then we have endometrial ablation, which is a destruction of the endometrium and can be done in an old-fashioned way using a resectoscope, or can use devices like NovaSure. And the NovaSure, this is the sort of demonstration of how the NovaSure works. And it has its own sort of limitation or contraindications. If you have infection, if you want to preserve fertility, it's not a good option in postmenopausal women, or if you have a large cavity. Very important option is the endometrial ablation, because a lot of women requesting it in the city or where I work. They have, very important to know that it only reduces the heaviness of the period. It's only 20% chance that they might not have a period again. The last statement is about hysterectomy, and it can be done all different ways: vaginal, laparoscopic, robotic, abdominal, total, subtotal, where you leave the cervix or take it out, take tubes out at the same time, remove ovaries, depending on the age and the risk factors. And we have to address all the risk and complications. So when you apply these standards of care, and when you counsel the patient appropriately, you will find most women will be happy to the sound of no more or less period. Thanks a lot.
Thank you, Dr. Jumaira, for an interesting talk. Thank you. Now I will present our second speaker for today, Dr. Media Elias. Dr. Media is going to give us a talk about an update on hormone replacement therapy and perinatal testing. So Dr. Media has finished her training in various institutions in Victoria and in New South Wales. She obtained her fellowship from Royal Australian New Zealand College of Obstetrician and Gynecologist, and since then has been working as a consultant obstetrician and gynecologist in both public Western Health, Sunshine Hospital and Private Hospital in Melbourne, at North Park Private Hospital in Bandura, Western Private Hospital in Footscray, and San Vincent Private Hospital in Werribee. She has a special interest in colposcopy, advanced laparoscopic surgery, endometriosis, menopause, prolapse and pelvic floor repair, and high-risk pregnancy. In addition to all of the above, Dr. Media has the following roles. She's an examiner for Australian Medical Council. She is a training supervisor for the Royal Australian and New Zealand College of Obstetrician and Gynecologist, and she's a former discipline leader and examiner of the medical students at Notre Dame University. Please join me in a warm welcome to Dr. Media.
Thank you so much, and good morning, and sabah al-khair kulkum. Thank you so much for the invitation. I feel really honored and privileged to present in this very nice conference, and lovely to see you all. And special thanks to, I think, Dr. Ahmed Al-Rubai. You don't have to forget his massive work to put this together and bring us all here. I've been given 2 talks and time limit of 20 minutes, so I will try my best to fill in 2 big topics. The first one is about aneuploidy screening in pregnancy, and what can we offer in that field. Yep. The main objectives of the talk will be to be able to educate patients regarding the options for prenatal genetic screening, including the benefits and the limitations of the test. And also to be able to explain the meaning of the prenatal genetic screening, results, and then the next step. The two questions that most patients walk in asking is my baby normal? And doctor, can I please have the Down syndrome test? The most common chromosomal cause of birth defect and intellectual disability in both children and adults is Down syndrome or trisomy 21. And this is why most lay people focus on it. And it accounts for about 52% of all major chromosomal conditions currently detected through prenatal testing. And as we know, the prevalence of Down syndrome screening has direct relation to the maternal age. And we can look at that curve and see that rise of the curve depends on the maternal age, and that rise starts from the age of 37. But truly that the curve will start curving up from the age of 35. So that's why we call it as maternal age from the age of 37 in obstetrics, because of that increased risk. And the options for aneuploidy screening, we have three main tests. The first trimester combined screening, where they have the blood test done at 10 to 11 weeks, and combined with the ultrasound scan for the NT between 11 and 13 completed weeks. It has a detection rate of 75 to 85%, and it allows early morphology detection of any fetal abnormalities. The second trimester screening will have less detection rate of 70 to 75%, and we can do it later in women who miss the first trimester screening between 15 and 20 weeks, but they all need and must have a dating scan for that to be done. And the newest one is the non-invasive prenatal testing using cell-free DNA. That has much higher detection rate of 99.5% and can be done anytime from 10 weeks, and it must have a dating scan to allow any information about possible abnormalities. The cell-free DNA, which I will focus on a bit more, we know that cell-free DNA are short fragments of DNA released into the bloodstream through the natural process of cell dying or apoptosis. And during pregnancy, the mother's blood contains cell-free DNA both from her own tissues and also from the fetus through the placenta. And about 2 to 20% of total cell-free DNA in maternal blood is placenta, which is what the test is mainly focused on. The fetal component of that is known as fetal fraction. The main three trisomies that get tested on the NIP test are trisomy 21, trisomy 18, and trisomy 13, and also look at sex chromosome aneuploidies and microdeletion. And if the woman chose to have the NIP test or the cell-free DNA testing, we know much more about it now than before. It was started in 2013. It has very high sensitivity and specificity rate, and it is the best screening we have now for Down syndrome. However, the cell-free DNA is currently more expensive than other screening. It has no Medicare or private health insurance rebate. And clinicians should inform the availability of the test as an alternative, not a combination of the other screening tests. And if the woman chose to have the cell-free DNA testing as a primary screening, they still should be offered the 11 or 13-week scan or the NT scan for early detection of any major abnormalities. Because 50% of very early abnormalities can be detected with a good quality scan. And combination of cell-free DNA with the maternal serum screening test is not really advisable because it increases the false positive rate and does not increase the detection rate. But also it will add more cost. So when is the NIP a good option? It's a good option for advanced maternal age. It's a good option when there is an increased risk in the first trimester screening test, and in women who have had previous trisomies, or they basically just want to know. When it's not recommended, and when the woman really wants a definitive answer, I want to know 100% sure if this baby is normal or not, it doesn't give us the definitive answer because there might be other chromosomal abnormalities that are not tested. When there is clear abnormalities on the scan, and it is not going to give us or add anymore, we will need diagnostic tests. And when the risk is clearly very high, more than 1 in 50 on the serum screening test, then we should not add another test, but also the time delay with another testing before the diagnostic test. So in summary, the advantage of the NIPT test or the cell-free DNA is an excellent detection rate, has low false positive rate. It can be done as early as 10 weeks. It's non-invasive, and it gives us a clear cut. But it is expensive. It is non-diagnostic. It's still a screening test. Positive test result will require further confirmation with diagnostic tests, and does not screen the entire genome. And we also can have failed result from low fetal fraction. So if we have a patient walking in, she's pregnant with her first pregnancy, really wants to have the test done, but then we receive the test and the test result says that the test has failed. What do we tell the patient? We know that this is the test limitation. It can fail in about 1 to 8% where there is no results reported. It doesn't mean it's abnormal, it's just no result will be reported. And in those cases, 50 to 60% of that can be redone by a subsequent redraw, and the performance of that will depend largely on the fetal fraction. The factors that can affect the test result is the gestational age, the maternal obesity, and the chromosomal abnormality presence. What about the multiple pregnancies? All multiple pregnancies, twins, triplets, and above need to have a first trimester screening test for chronicity and for early fetal morphological abnormalities. In twin pregnancy, cell-free DNA can be done and can be offered with appropriate pre-testing, and also the mention of the slight increase in the test failure rate. It can also mention or give us an indication about fetal sex, but if there is a Y chromosome present, then it will not be able to say both babies are males or when. If there is a pregnancy with triplets or high order of pregnancies, then the main screening for chromosomal condition should be performed by the first trimester screening in addition to the other markers. Take-home messages is that the NIPT test is not diagnostic test, it's a screening, and abnormal results still require confirmation with diagnostic test. There is currently no Medicare or private health refund for the test. It's an option for the women who will be able to self-fund the test on their own. And pre-test counseling is very important about the test limitations, the results, and the further steps if the test is positive. And due to public health awareness now, most of our patients walk in and they're actually asking us about the test before we mention it. The screening should be an option that's mentioned to all women in all ages, not just in women with older women. And cell-free DNA has excellent sensitivity and specificity, but it has its own limitations. And all testing, as well as the cell-free DNA, should be voluntary. So it is not a must that the patient should go for it. And a good quality scan is really important in that matter. And the next test is not recommended in the presence of any structural abnormalities, and a good quality scan will ensure that once the test has been formalized, then we should have a clear pathway for the patient of what is next if it's positive with a further counseling. Thank you. So I hope I was on time.
Yeah, excellent. On spot.
Great.
The next talk now takes us to the other end of women's menstrual life, which is menopause. So this topic is about hormone replacement therapy, and I really try to make it a little bit easier for us all in the 10 minutes. And the two main objectives would be to refresh our memory and strengthen the basics of hormone replacement therapy and clarify the risk, benefits, and also clarify some myths around hormone replacement therapy. Menopause is cessation of period or menstruation, 12 months from the last menstrual period, and the average age in Australia is the age of 50 years. Perimenopause is that period transitioning to menopause that has wide range of symptoms, but really it can last for many years, from the age of 45 to 55 years of age. The premature menopause is when menopause happens below the age of 40, and that accounts about 1% of women. And early menopause is when it happens at around the age of 45 or less, and about 5 to 20%. These are the symptoms that we try to control and treat. So lucky for all the men in the room that they don't know what we're talking about most of the time. But we treat these symptoms mainly to avoid the 7 stages of menopause. It is challenging because 1/3 of a woman's life she goes through menopause, so that is more also with post-cancer patients and survivors, and they have breast cancer or oophorectomy, and they have early menopause surgically because of that. Quality of life is important. Often this requires multiple visits. We're all busy and we are on time restriction. The main hormone replacement therapy that we use is estrogen, the progestogen, which is used as an endometrial protection to avoid endometrial hyperplasia, and testosterone that we use sometimes. These hormone replacement therapy are truly effective and probably the only way of controlling the menopausal symptoms. And it also has benefits for bone protection. It comes in variable preparation of different doses, types, and routes of transmission. In terms of safety of hormone replacement therapy, the 3 main areas that we need to cover: the risk of thromboembolic disease, risk of heart disease, and risk of death. And we need to discuss with each and every patient each time we see them for hormone replacement therapy. And the 2 main regimes are estrogen and progesterone combined, or estrogen only in women who have had a hysterectomy, because we don't need to do to add progesterone for endometrium. The benefits of hormone replacement therapy, the main one is to control the symptoms, improve bone density, and reduce the risk of fractures. It will also reduce cholesterol and reduce the level of diabetes, and it does not add into the weight. But if we take the risks one by one, and if we talk about how much is the risk of thromboembolic diseases, we use combined estrogen and progesterone regime in an oral form, tablets, then the risk of thromboembolism or blood clots doubles. Sounds scary when we tell the patient we're doubling the risk, but we are really, the true added risk is 1 case per 1,000. So the actual risk is not very high. Yes, it's doubled, but it's not very high. The risk of heart disease, estrogen and progesterone combination, does not increase if it started within 10 years of menopause. Estrogen only may provide some protection. In saying that, hormone replacement therapy should never be used to prevent heart diseases. That is not an indication at all. The risk of breast cancer, there is no increase in hormone replacement therapy use, and risk of breast cancer if it's used for 5 years or less than 5 years. Combined hormone replacement therapy use, the risk can increase after 5 years, but again, that risk is only by an added 1 case per 1,000, not a major increase. And that risk can be reduced by careful selection of progesterone component, and we use natural or the high progesterone that will not increase the risk of the breast cancer. And estrogen only will not increase the breast cancer, so for women who have had a hysterectomy. Risk of stroke, there is no increased risk or added increased risk of stroke for hormone replacement therapy users in women without any underlying other causes like smoking or high BMI or alcohol. Local symptoms, many genitourinary symptoms, will be treated with topical treatment, and that's the only way of controlling the topical symptoms. And we don't have to add progesterone in that case for endometrial protection. Topical use will only affect the serum level very, very little. Can it be used for over 5 years? It is possible to continue hormone replacement therapy after 5 years with proper consultation and with individualized assessment. And and women with early menopause, less than the age of 45 or 40, they should continue their treatment up until the age of 50 for their benefits. Tibolone is unique and slightly different. It has estrogen, progesterone, and also androgenic effect. It also does not increase the risk of breast and density, and also we don't need to add progesterone with it, so it's a one-off treatment. And it does not increase the thromboembolic disease. Like any other medication, hormone replacement therapy will have side effects. The main ones are headaches, breast tenderness, fluid retention, bloating, nausea, and mood swings that the woman will initially have in the first few weeks. Most of the time, these symptoms settle with ongoing use. When do we stop it and how do we stop hormone replacement therapy? Two choices, either by suddenly stopping the intake or gradually reducing it. Reducing the hormone replacement therapy gradually will have lesser effect on the short-term symptoms, but really no long-term effect either way. Take-home message is that hormone replacement therapy is more effective treatment for menopausal symptoms, and improved quality of life and sexual function, and improved joint-related aches and pains, and sleep cycle, and also vaginal atrophy. For the majority of women, the benefits will by far outweigh the risks, and if it's used or initiated below the age of 60, and consider the risk and the benefits as per individual base, and aim to commence the hormone replacement therapy within the first 10 years of menopause, and consider transdermal preparation or drug preparation to reduce the risk of thromboembolism rather than oral intake. And there is no evidence that increased breast cancer risk with the use of vaginal estrogen that can be used safely. The feedback from the patient we get when they happily control their symptoms is that they finally get someone listening to them, their symptoms were controlled, they have better quality of life, and they all acknowledge that yes, this is a condition unique to women, but nobody can ignore the big portions of men and their role in our problems. Thank you.
Thanks, Dr. Media, for a very interesting topic. I'm sure it will raise lots of questions, which we will have time for it after we finish our last presentation. Our next speaker will be Dr. Imad Mahmoud, who will give us an update on endometriosis. So, Associate Professor Imad Mahmoud is a consultant obstetrician gynecologist in Northwest Sydney. He holds position at Blacktown Hospital, Northwest Private Hospital, and Macquarie University Hospital. He completed his undergraduate medical degree at Mosul University and his specialty ONG training in Sydney. He has done further international training in advanced robotic and laparoscopic surgery and has developed a special interest in endometriosis and pelvic floor reconstruction surgery. Associate Professor Mahmoud is a senior member of the Sydney Western Area Pelvic Surgeons, SWAPS, which is a highly sought-after program that enables trainees to train further and improve their surgical skills and knowledge. He is committed to teaching and supervising junior colleagues and also trains doctors internationally in Thailand and Iraq in advanced robotic surgery. Please welcome Dr.
طبعا هذا أنا لما كنت شباب. Thanks for everyone. Thanks for attending. The actual presenter for this talk was Dr. Haider Rajab from Melbourne, but in the last minute he couldn't come, so we had to make some changes. And my talk went to Dr. Farjo, and Haider's talk came to me. So last night I was just going like crazy trying to get my head around. Yeah, so we thought. بس أنا زرعت شعر. Okay, can you hear me? Okay. So Dr. Haider Najjar's talk was about endometriosis and fertility. I had a talk which was very long, so I thought I'll use his talk for the sake of time. So learning objective is to learn about signs and symptoms of endometriosis and adenomyosis, understand the limitation and gold standard of diagnostic tools, management of endometriosis and adenomyosis, including multidisciplinary and holistic approach. impact of endometriosis on the fertility and its solutions. So theories about pathogenesis. So we all know that it is multifactorial disease. There's no one knows exactly why endometriosis, what's the reason of endometriosis. The most common theory is retrograde menstruation. There are some other theories like altered mechanism. Other sources include stem cells, mesothelium, lymphatic or vascular dissemination. And also there's a theory about pre-menarcheal endometriosis. So there are some theories saying that someone has had endometriosis even before they start having periods. Or some genetic causes, which none of them is proven, to be honest with you. Incidence, to be honest, endometriosis is most common than we think. It's actually very common. And the more I see patients, the more I see people coming with different symptoms that it may raise the suspicion of endometriosis. So people aged between 30 to 34 most likely to receive this diagnosis, and the incidence is 1 in 9. On average, it takes about 6.5 years to be diagnosed, because people go to the GP with heavy period pain, pain going to the legs, pain going to my back. They get treated with different diagnoses until they reach to someone who raised the index of suspicion for endometriosis. And it's recognized by NHS as it is top 20 most painful conditions in the world. Signs and symptoms. Probably our GPs in the room and other specialties also know that it has the most common symptom is the pelvic pain and period-related pain like dysmenorrhea, and affects people's daily activities and quality of life. Deep pain during sexual intercourse called dyspareunia. Period-related cyclical GIT symptoms and painful bowel movements, which we call dyschezia in our medical language. Period-related cyclical urinary symptoms and hematuria with period time if they have bladder endometriosis. Infertility in association with one or more of the above or none of the above symptoms. So basically, sometimes patient comes, they can't fall pregnant, and when you investigate them, you find they have endometriosis, which is causing infertility, like blockage of the tube, but they don't have pain, no pain. So it's very weak disease. So, and as we said, symptoms can vary from none to severely disabling pain. No good correlation between severity of symptoms to severity of the disease. So you might find a lady has stage 4 endometriosis with no pain, or someone have very superficial endometriosis, they have severe pain. Symptoms may correlate with the site of the disease. As we know, endometriosis can present anywhere. Sometimes in the lungs, sometimes in the brain, sometimes under the skin. And for example, if someone has cyclical hemoptysis or cyclical pneumothorax, can raise the suspicion of endometriosis. And also if it's under the skin, you might find there's a lump which is getting bruised and thickened and tender every time they have periods. So what to do? As we know, go to basic history, examination, investigation. History is type and timing of the pain, cyclical pain, as we said, severity and how it affects the quality of life, how much analgesia they take, does it affect the fertility, and when you examine, so if it's very obvious endometriosis, if you do pelvic examination, when we call it bimanual examination in the gynecology, you might find the uterus, we call something called cervical motion tenderness. When we push the cervix, it's very tender. And you might feel nodules or tethering around the uterosacral ligament in the posterior fornix, or you might find a mass, which can be endometriosis in the ovary, endometrioma. Ultrasound by well-trained ultrasound doctors like Dr. Juman or Dr. Vatul can be helpful comparing to the general ultrasound places because they know where to look for endometriosis, the nodularity in the uterosacral ligament, or they can look into the endometriosis in the pelvic sidewall. That's why when we refer, we always refer to tertiary units, not like a normal ultrasound. They do gallbladder or shoulder and stuff like that, so they don't need to be trained like Dr. Fajr or Dr. Nadeem. They are trained specifically for this. Other imaging can be helpful. It could be MRI, especially if you want to look for presence of nodules or bowel involvement, especially between the rectum and posterior cervix, which is called rectovaginal fascia, and you can see that there is a nodule there, and that will be helpful for surgical planning. As a gynecologist, when we have grade stage 3 or stage 4 endometriosis involving the bowel, we need our colorectal colleagues to be there so they can help to clear the bowel so we can do our part. Tumor markers like CA125, it's non-specific and it's not recommended to do. If you do it, it will show you it's a bit high, but it's not going to help you. And when to refer patients. Consider referring patients if they have severe, recurrent, or persistent symptoms, signs of endometriosis on examination, and signs of endometriosis on ultrasound, or adenomyosis, endometrioma, and symptoms of DIE, which is deeply infiltrating endometriosis. Initial management is not effective, not well tolerated. So if you are a GP and someone coming with a pain and heavy period, and you give her the pill, you give her non-steroidal, you give her all these basic, and then still not responding, then probably that's time to refer to a gynecologist. Or someone for fertility, refer for pregnancy and fertility planning, and usually endometriosis treatment need multidisciplinary team, especially if it is advanced stage 3 or 4 endometriosis. We might need urologist, colorectal, or upper GI if it is under the diaphragm. So this is some pictures. This is so this is a normal uterus, normal ovary, normal tube. You can see this is the pouch of Douglas, left uterosacral ligament. This is all normal, right ovary, left ovary. So this is the pouch of Douglas, and this is the rectum here. When this is obliterated, that's considered advanced endometriosis. And this is the normal cavity of the uterus. This is, you can see the pouch of Douglas here has superficial endometriosis. And there's superficial endometriosis in the right ovary here, small black dots, red spots. And here, everything is, the pouch of Douglas is blocked with severe disease. And here's the right ovary. Left ovary is stuck to the left uterosacral ligament. You can see the difference between this and that. This look very messy. Again, there are some photos here. We have this dark area is endometriosis in the left pelvic side wall, and this is after it's resected. Here again, it is, you see, causes scarring and damaging to the peritoneum and can infiltrate deeper and deeper. And this is after it is excised. Empty staging, stage 1, stage 2, stage 3, stage 4. So the more superficial it is, it's less staging, and the more deeply infiltrates, the staging go higher and higher, and then starts adhesion and destructing the organs surrounding, like it starts nodularity from the uterosacral ligament, goes into the ovaries, and then involves the bowel, then involves the bladder, and it's not cancer, but it can start destroying locally, damaging the surrounding tissues. Adenomyosis is another topic, but it is related to endometriosis. It's called the bad cousin of endometriosis, because instead of the endometrium going outside of the uterus, it is infiltrating into the wall of the myometrium, causing thickening of the wall of the uterus, which means every time they have periods, they have pain. It also can cause dyspareunia and also heavy bleeding. and it affects 20 to 30% of women, and also 50% of people also have pelvic endometriosis when they have adenomyosis. It's estrogen dependent, same like endometriosis, flares up with the estrogen. Diagnosis of adenomyosis, there is no universal classification for the diagnosis. At least with this pelvic endometriosis, we do the laparoscopy and we can confirm, and we take biopsy, but when it is in the wall of the myometrium, you can't dig into the myometrium and take a biopsy, especially if they are still premenopausal and they want fertility and kids. So we can also only suspect, but again, our ultrasound colleague, they are very good at telling the signs of endometriosis, which include Venetian blinding, heterogeneous looking, and globular features. And this is, you see the ultrasound showing thickening wall of the uterus, and this is the MRI. See that the endometrium is in line in the middle, and the posterior wall of the uterus is thickened, and I think it could be adenomyoma. I don't know, Juman, what do you think? Yeah, it's small, like adenomyosis. Management, so we have medical treatment and surgical treatment for endometriosis. So it depends on how bad are the symptoms, so we need to tailor according to the individual needs and the preferences and priorities in terms of pain and fertility. Simple analgesias a lot of time could be enough, like paracetamol and non-steroidals. Hormone therapy can reduce pain and no permanent negative effect on fertility. That's what always they ask me, doctor, if we put Mirena, can I have babies? Of course you can. It's not going to affect. If I'm going to have a pill, I'm still 17, is it going to affect my fertility? It's actually contraceptive, and it is when you stop, you are fertile again. So the good news is the hormones work to shrink the endometriosis. Other treatment is GnRH agonist and antagonist used in the setting of deeply infiltrating endometriosis, pre or post-op. So if someone, in my practice, I excise the endometriosis, I put Mirena in, and I assess them in 3 months, 6 months time. If the pain is existing, I'll add some more oral progesterone, and then I assess them in another 6 months. If they are not still responding, my GnRH agonist will be my last resort. I'm going to just jump into it because it gives them menopausal symptoms, because it stops the ovaries from working for 6 months. So they get hot flushes and side effects, headaches, hair loss. Non-pharmacology treatment like behavioral, psychological medicine, lifestyle, exercise, relaxation, mindfulness, complementary medicine, acupuncture, TENS machine, herbal medicine. I don't know how much it works, but people try it. Allied health, physiotherapy, pelvic physiotherapy, especially if they have dyspareunia and bladder and bowel symptoms. Surgical management, the aim is to remove any endometriosis deposit and to normalize the anatomy with minimal tissue destruction, especially if the fertility preserved. So we try to, if the ovaries are stuck to the pouch of Douglas and the person is, the lady is infertile and she's going to IVF clinic, so we as a gynecological surgeon, we try to mobilize the ovary, move the bowel out of the way so the IVF person can do egg collection vaginally for the patient. There is ablation versus excision of endometriosis, and so either you burn it or you take it, cut it. There is a lot of debate whether excision is better than ablation. I personally think excision is better. Laparoscopy is preferred way of diagnosis and treatment, has a short recovery. I added this line to Hyder's presentation. Also, robotic surgery provides 3D vision and has better access if robotically trained gynecologist. Severe endometriosis involving bladder or bowel may need multidisciplinary approach. As I said, we need the urologist, we need the colorectal surgeon to help us to mobilize the bladder or cut incision from a bladder. Our insurance doesn't cover that. And also for colorectal to help us to mobilize the sigmoid, the colon, and I don't know whether you heard of the kissing disease, kissing ovaries, when they come with endometriosis to the middle and they're stuck and the rectum is in between, and we need the colorectal surgeon to help us with mobilizing the bowel. Primary surgery is very important because the outcome may be increasingly poor with subsequently performed serial procedures. So if someone has endometriosis, it's better to be done the first time, to excise as much as you can of the disease, because the scarring happens for the next time, then it becomes difficult to find the planes. So recurrence of endometriosis is high. 40 to 50% of patients will become symptomatic, and 30% will need another surgery in 5 years. In patient not wanting immediate fertility, consider hormonal suppression immediately. As I said, excise the disease and put some hormonal suppression. And also always talk about fertility, testing of fertility. If you think you've done extensive disease, probably it's better to do AMH level before and after of to check for egg reserves. Egg freezing, another option if you think you've kind of damaged ovary with the treatment. Surgical treatment of adenomyosis, difficult if fertility preserving, required mainly symptoms management. So adenomyosis, as I said, it is in the wall of the uterus. It's an endometriosis in the myometrium. So it's not like peritoneal endometriosis that we can remove. Sometimes there is a adenomyoma that forms in the myoma, which looks like a fibroid, which looks like round, and then becomes a problem when you want to remove it, because you're going to cut into the myometrium. Endometrial ablation that Dr. Juman talked about for heavy period to reduce bleeding, but not, this is of course for someone who doesn't want fertility. If they have menorrhagia, you want to reduce the heavy period, but you will burn the endometrium, but the myometrium is still painful. Every time they have periods, they will have the cramps. So in short term, the best solution for adenomyosis, in my opinion, is hysterectomy or Mirena. If they respond to Mirena, the Mirena will give progesterone locally into the myometrium, and it will relieve the symptoms. If Mirena doesn't work, I think hysterectomy is the best. GnRH suppression, but you can't use that a long term, is usually 6 months, and hysterectomy, as I said, as a definitive treatment for adenomyosis. This is a thickened wall of the uterus, and then when they cut it, it is adenomyoma, and they sutured it. As you see, it damages the wall of the uterus. If fertility required, in this case, probably she needs cesarean section, because the wall of the uterus is already weakened, and they might have a rupture of the uterus if they have a baby. Take home message, 1 minute. It's common, early referral is important, history of examination and pelvic ultrasound is important, treatment needs to be individualized and need according to the need of the patient, age, symptoms, fertility, desire, and work and family. And this is just a quick video showing you how this is the uterus, and see how it is. This is called chocolate cyst. The ovary is stuck to the back, and this is the kissing ovaries. There's ovary on the other side after separation. Left big endometrioma. This lady wants to fall pregnant. So we're normalizing the anatomy to prepare her for IVF surgery. And I'll just show you that. the thick endometrium, like chocolate cyst that we call it. This is going quick. So this is the ovary stuck to the pelvic sidewall. It's very messy disease. And that's the rectum here. There's the ureter underneath. We put something called ICG in the ureter to identify the ureter. I've done this surgery with Dr. Colorectal surgeon, amazing one. His name is Walid Barto. Anyone heard of him? Any GPs know Walid? If you need a colorectal surgeon for endometriosis, it's Walid. Okay, hold on. Betul is giving.
Thank you very much for this comprehensive reviews. I'm sure there were lots of very informative information in there. Now, our next speaker is Dr. Salwan Al-Salehi. He's going to give us a talk about pelvic floor dysfunction, urinary incontinence, and pelvic organ prolapse. Dr. Al-Salehi gained his primary degree in medicine and surgery from Baghdad University in 1992 and received extensive experience in medicine and surgery working in various parts of the world. After completing his general obstetrics and gynecology training in New Zealand and Australia, Dr. Al-Salehi received formal training in urogynecology and pelvic reconstruction surgery at the Royal Women's Hospital in Melbourne. Dr. Salehi occupies the position of the head of the unit of urogynecology department at the Royal Women's Hospital in Parkfield since 2016. Dr. Salehi has a special interest in laparoscopic and minimal access surgery as well as robotic surgery in pelvic reconstructions and urogynecology. Please welcome Dr. Salehi.
شكرا بتول على الانترودكشن، وشكر خاص للأحمد للأورجنايزنج الميتينجز. يزيدني شرف انه انطي التوك هنا. بس قبل للتعريف، لان هوايه ناس actually ما يدرون شنو يعني يوروغاينيكولوجيست، وهذا طبعا هذه مشكله عامه. اليوروغاينيكولوجيست هو سب سبيشالتي يجي ورا 6 years of doing gynecology تسوي another 3 years لانه تحب انه تعذب نفسك اكثر. It's specifically about the pelvic floor support and pelvic floor complaints. Please feel free to intervene and ask me questions halfway through. This is the learning objectives of the talk. Pelvic floor dysfunctions comes into the 4 functions. So overactive bladder, urinary stress incontinence or urinary incontinence, and pelvic organ prolapse and fecal incontinence. This is simplifying everything in between. To start with, the bladder overactivity or overactive bladder, or used to be called as urgency or urgent incontinence, it's a very common conditions, very, very common conditions. This is an international check on how often it happens for men and women, and can occupy up to 1 in 3 in women in different part of the world, and internationally is about 1 in 3. In terms of how much risk factors can work around the suspected occurrence of bladder overactivity or epidemiological risk factors for them it falls into age. However, that age is actually slightly irrelevant nowadays because you can actually pick it up as early as 18. In our case, pediatric urogynecologists or pediatric urologists actually can pick it earlier, and as late as in the 90s. The occurrence of pelvic organ prolapse, as well as the neurogenic diseases, comorbidity, BMIs, lifestyle choices, all contributing factors to not causations, but making things worse for those women. In terms of caffeinated beverages, alcohol intake, all add into the bladder overactivity issue. And one of the first recommendations is for them to moderate their level of intakes of caffeinated beverages as well as alcohol, because they all contribute to the bladder irritations and function. It's a bit of a important subjects and very delicate subjects actually to broach, because the ramifications actually is a bit extensive. It starts actually by women having to have poorer quality of life when it comes to actually incontinence and prolapse. That causes them to reduce their physical activity, that lead to actually to psychological outcomes, to be isolated, as well as actually as increased weight, which goes back to feed into the bad functions of the pelvic floor. So all in all, we need to break the cycle at some stage, and one of breaking the cycle elements actually is to ask the question, do you have a problem controlling bladder or bowel? Management's classifies based on the American Urological Associations back in the earlier decade is first line therapy. We have to talk about the bladder diet, the bladder trainings, pelvic floor muscle trainings, using the easy steps to start with. And the second line of therapy, which is the medications for bladder overactivity, and only the last ones will be the surgical or PTNS or Botox or interstem pacemakers for the bladder. The reality checks regarding that is not so people actually have to suffer for extended period of time before actually we say to them, yes, you can actually have the final solutions. It's literally is built based on the health funds that actually has the health economy. No one actually would like to come and actually and use while they had the symptoms and the debilitative symptoms for about 20 years, they don't want to spend another 6 months here or 6 months there in order to get to here. But the health systems and the health fundings actually is disabled by the amount of the number of patients actually can attend to that, and therefore this is created to accommodate for everyone. And unfortunately that goes without saying in Australia as well. To start with, preventions, there aren't a lot of preventions actually to work with it, other than education, keep educating, pick up the early signs and symptoms, as well as actually address them, and let's not be scared to talk about bladder health anymore. Lifestyle changes, weight loss, it's intimately related to the bladder functions, and some studies suggesting reductions of weight by 5 to 10% may reduce the symptoms by 70%. It complicates everything else. It's not make or break, but it is regarded as a grade A recommendations that please lose weight before we start on more extensive treatment, because it will help you on a longer term. It reduces the amount of interventions and reduce the amount of potential use of pharmacological as well as surgical. Pelvic floor muscle training, contentious issue. It's important to endorse. How much does it make a difference? It's like many things with needing to be enforced with the intentions. It's like when you ask patients to quit smoking without the intention to quit smoking. You can say quit smoking or use quit programs till 2030, but it's not going to happen unless they're motivated. Having to find patients that motivated to do pelvic floor exercise may benefit. It doesn't benefit. It doesn't actually change the outcome to a major extent, but it may improve the outcomes with available treatment. So it does have role there as for advanced cases, but at the same time it does have role for the grey area patients, which they don't have very severe symptoms. All what they need is re-educations and reinforcings of those pelvic floor muscles. The things is sometimes the flip side. Physiotherapists would say it's like working on your biceps. It's not like working your biceps at all, because the attachments of the muscles for the pelvic floor, it's nothing to do with the biceps. The biceps, by definition, is two heads. The pelvic floor is probably about 36 attachments in one location only. So therefore, it does not work in the same way. In order to not to make the patients feel very disabled by that notion, just say do as much as you can, and we'll pick up the rest. In pregnancy, there are some reports suggesting that actually endorsing pelvic floor muscle trainings in the first trimester, up to the second and third trimester, and the first 6 months after the delivery, it may improve their general outcome. Unfortunately, it doesn't prevent their general outcomes beyond the first 10 years. If that doesn't work, then we talk about medications. What do we want from the medications that works on the bladder overactivity? We want the perfect medications. Easy to take, less side effects, more compliance, and great efficacy. Unfortunately, that medication doesn't exist. The first line of medication is the anticholinergic medications. Some of them the oxybutynin, which is it is non-specific. It's a horrible medication because it dries everything, and because of the availability of the number of of receptors everywhere. The more recent, when I say recent, means in the last 15 years, is the darafenacin, sulfonisin, because it works ideally on only M3, but they don't. They work somewhere else as well, and that's why they do have the side effects. Not as bad as the oxybutynin, and it's better for specific options. I find them to be very useful for the very younger generations, that pre-childbirth era, that they regulate the bladder, re-endorse how the bladder works, and retrain the bladder medically, and usually in good circumstances and good kind of communications, they stop medication after 12 to 18 months. And then there was the Betmiga, which is it is a bit of a kind of a IKEA moment when they started to look into the beta agonist receptors to force the bladder to relax. It's been around in Australia for around about 10 years. In Japan and the US, it's probably about 15 to 20 years. Comes in different strength, 25 and 50. The TGA suggests that we have to always start at 25, but normally it does not work until 50. Major side effects is interactions with blood pressure, and the labile blood pressure, not the mainstream chronic blood pressure. The ones that they have uncontrollable blood pressure may be you need to consult the physician if you want to put them on it. But you can give it for people who have closed angle glaucoma, because it doesn't work the same way as the other medication. And then the Botox, which is fantastic in every shape, form. The Botox only for the bladder. I don't do it for the face or anything else, but if I have a penny for every time a patient said, am I going to look younger? I said the bladder will, but not everything else. But the Botox really works very, very well. As you know, it's a botulinum toxin, beta botulinum toxin that works on the receptors of the acetylcholines, and it blocks the receptors at the urotheliums, and it replaces the receptors. So new receptors has to be generated by the system in order to go back to how they were. Injections is using a special needle. This needle is terrible needle, but recently the good needle, which is the Labrui needle, which has the specific guide to how deep you go, because where you want between the urotheliums and the muscles, and you don't want to be inside the muscle because of extravasations into the blood system, and at the same time it doesn't work as well. So at the urotheliums the depth is 2 millimeters. And as a standardized, I only use 100 international unit. The urologist, we all know the urologists, they're heartless. They give 200, 300. I'm joking, of course. But in our titrations of dose, if you use 100 and repeat it every 12 to 24 months, you reduce side effects, you increase compliance, and provide efficacy. Evidence behind repeated doses of botulinum toxin is very encouraging, and you can use it 20, 30 times. Unfortunately, 2.5% of populations may develop antibody against it, so after they develop that antibody, it becomes less and less effective. Luckily, we have other options, including electric stimulation. So electric stimulations, there are the external electric stimulations, or the internal electric stimulation, if you like. The external is called the PTNS, which is the percutaneous tibial nerve stimulations. That's done in the outpatient setting. So we put acupuncture needle and you attach it to a stimulator, and the stimulator is graded, and you do sessions, half an hour sessions for 12 sessions. It's heavily subsidized by the by Medicare. Normal cost of those sessions used to cost about $210 to $280 sessions. Now it's subsidized to the extent of the out-of-pocket for the patients, $30 only. However, they have to be committed to 12 sessions once a week, so that's 3 months. Unfortunately, 85% of patients don't show any response to it until the 11th or the 12th session. So they have to stay the long haul until actually they find out whether this is going to work or not. Once it's done, and it is effective, and there are some studies that suggest that actually it is effective, and certainly more effective than some of the tablets, and definitely more effective than only bladder trainings or pelvic floor muscle trainings. Then you put them on maintenance dose and maintenance treatments. The first one is for 2 months, and then after that, once a month for 6 to 12 months. It's very acceptable by patients. They like it more because they don't have to be hooked to anything. It can have some possible side effects. One of the weird ones actually is they do have very rare occurrence of cellulitis from 1 injection of acupuncture, which I find very weird, given that people, acupuncture therapists, they use about 25 of them, and they don't get cellulitis. How does that happen? I have no idea. Anyway, last but not least for bladder overactivity is the use of the sacral nerve modulation. It's been around for about more than 30 years. It's been TGA approved for bladder since 1996. It's been approved for fecal incontinence since 1992, I think. It's very interesting concept. What it does actually, it has 2 stages. The first stage is you introduce the lead, which is a tined lead, into the spinal space, which is S3, S4. And that work on stimulations. You use 2 weeks for trial, and that's dictated by Medicare. You have to have a trial because that is very expensive. It's about $23,000 for the health funds. So they want to see at least 55 to 60% improvement before you go to stage 2. This is the latest. I just implanted the first one in Victoria about 4 weeks ago, and that's the rechargeable version of it. It's the size of a USB, literally the size of a USB. You put it under the skin. So this is, as you know, actually is the same ones for cardiac, and you can actually feel them or see them for people actually with cardiac. This one is rechargeable. I'm not sure if there is rechargeable for cardiac or not, but this is rechargeable. You put a belt on it for 30 minutes every 10 to 14 days and recharge it. And the total number of years you can actually continue using the same battery for is about 15 years. So much better than this, because actually this has to be replaced every 4 to 6 years, depending on the use, but this one is about between 10 to 15 years. Very intricate procedure, but it's a life-saving procedure for a lot of patients. And the youngest patient that I put it for is 26, and the oldest patient is 89. The 26, she had no life prior to this, and since then she had normal bladder functions and normal activity, and like nothing's happening. All of the leads, as well as actually as the IPG became MRI compatible since 2021-22, and July 21 is the I think July 21 or 2. Those 2 years were blur. So I think over the last 12 months at least, every one of them is actually compatible with MRI. So you can put them for people who need MRI on a regular basis. It wouldn't have any interference. There's some evidence. This will stay with you guys, so if you want to have an access to the presentation, I have no problem, for interest of time. I put painful bladder syndromes because there's a lot of ignoring factor when it comes to complaints to GP about painful bladder syndrome, especially in the younger patients who started to have recurrent urinary tract infections since became sexually active. and they go with years and years of antibiotic and casual antibiotic and recurring antibiotics without anyone asking, could that be interstitial cystitis? And the diagnosis is actually maintained by a cystoscopy and hydroextension with or without a biopsy. And then the treatment, which I think changed the game dramatically, which is hyaluronic acid. Again, this is not for the skin, as L'Oreal advertises for the skin, but this is not for the skin, this is for the bladder. So that actually makes a huge difference to the interstitial cystitis, and I saw it firsthand how it does repair for the lining. The next step is actually the stress incontinence. Stress incontinence, they used to say if you have to choose to have incontinence, which no one does, that you should get stress incontinence. Why? Because it's very well manageable. Up until it became very controversial of how you treat it, and then we enter the mesh issue, which I'll mention very briefly, just for the sake of boredom. So stress incontinence is the stable bladder and inability to control the leakage of urine, uncontrollable leak of urines on the start of increased intra-abdominal pressure. So that becomes very kind of like intricate when people actually look into urodynamics and they see actually, oh, the bladder pressure goes up. That means this is a stress incontinence. It's not. It's actually, it should be a stable bladder with uncontrollable leak due to increased intra-abdominal pressure. It's by definition, it's a weakness of the neck of the bladder.
1 minute.
I'll exceed that by a couple of minutes. So this is not a solution. It's advertised and everywhere in the public. Actually, if you have little bladder leaks, use a pad. Using the pad is not a solution. It's, if anything, is the start of the problems. And then we'd say, so you would say actually surgery. I said, yes, the surgery is the solution. So the surgery is, there are 4 endorsed surgeries. The sling, which is like in certain medias actually is like you're saying the devil's name or Voldemort, bulking agents, birch copper suspensions, and pubovaginal sling. So I'll just mention it very, very quickly, and please feel free to ask me after this if you want more explanations. So the birch copper suspensions used to be the gold standard in between 1965 all the way to 1999. It's by pulling the neck of the bladder at the level of the mid-urethras with using 2 permanent sutures. I stress on the fact permanent sutures. Dissolvable sutures do not work. There is only one study, used 35 patients with dissolvable sutures, and they said it is the same, but it's not the same. And that lifted and sutured to the ligamentum of Cooper through the access into the spacer tracheus. Does it work? It does work. Efficacy probably between 67 to 85%. Unfortunately, it doesn't work beyond the 10 years mark. It can have side effects. One of the main side effects is voiding dysfunctions up to 10% in the first 6 months, and as well as actually can cause posterior vaginal wall prolapse by definition, and it can cause bladder overactivity by up to 25%. Now, I won't bore you with that. Sling. It is the single most successful inventions when it comes to actually urinary incontinence in the history of urinary incontinence or surgery. Why? Because there are over about 4 million women around the world actually who have them, and even though that people say it causes erosion, it causes this, it causes pain, which it does. Those are all correct, but they are used by the wrong people for the wrong persons and did it very wrongly. How it works is actually it is substitute what it's called paraurethral ligaments. So whenever the bladder necks mobilize under the effects of the pressure, it's stopped it from leaking. Its efficacy is about 89 to 90% even after 25 years. The risk of exposure, or what they used to call it erosions, is about 1 to 5% depending on the patient. Diabetics, smokers will have more likely to happen. It works. It really works. The problem about it actually is was underestimated by a lot of people, including the companies that sold them. It's a simple procedure. It's not a simple procedure. It's a very delicate procedure. And I used to kind of run cadaver workshop, and I used to say to specialists actually, if you get to the level that you think this is very simple and everyone can do it, you should stop doing them, because they're not. Anyway, other procedures, I think, and again, you can access those. Bulking agents. Bulking agents like a filler. People will say, actually, you use Botox for the bladder, you use hyaluronic acids for the bladder, and you use filler for the bladder. What have you left to the plastic surgeons? This is, no one will see it, but this is a filler that bulk up the neck of the bladder in order actually to reduce the leakage. It used to be microplastic, which is this, doesn't exist anymore. This is a water-soluble polymer that it's very efficacious, cheaper than the macroplastics, works really well, especially for limited activity patients. Last but not least is fascial slings, which is when we take a sling-like object from the rectus sheath and put it as a sling. It's an extensive procedure, it's very successful. It's usually dedicated for someone who's tried everything under the sun, nothing's worked. Second, it's high morbidity because it can cause voiding dysfunctions by up to 25%. It's certainly used for people who had radiation therapy, people who had multiple surgery before or injury to the urethra. This would be a very good procedure. I'll just mention prolapse very quickly. It's a very important subject actually to ask the patients because, and in associations with urinary bladder functions, because it is intricate to that, and having to address the bladder symptoms without addressing an existence of a prolapse means you haven't done a thing. So that's why it's important actually to look for it, examine, and as well as actually be mindful that the patients actually do have it. It's present in 98% of women with vaginal birth. It can still exist with people who have cesarean section, as we know from one of the prolonged studies that cesarean section only protects you for 15 years, not more than that. You can use pessaries for different reasons, and you can use surgeries. Surgeries are simple vaginal wall support, apical support, or the mesh surgery again. The uterine conservation surgery is something that's very close to my heart because actually I really believe in it, and it actually addresses the prolapse dramatically, and it is very, very successful. We have 78 patients in a study that actually we followed for 7 years, and they had 93% success rates after 7 years. It's outside the scope of this talk to talk why, if you lift the uterus, everything else will fit in place, because 60% of the vaginal wall prolapse attributed by the uterus. So people who address the vaginal walls without addressing the uterus, they're missing out on 60% of the prolapse. Sorry, I'll finish. Yeah. Uterosacral ligament suspension is a new surgery that I'm doing at the Women's, and I have two of my fellows actually doing PhD on it. It's a new harvesting of the uterosacral ligament internally and repositioning it in a different place. So far the result is very good, but we're presenting it in IAMA in the Netherlands next month. Those are gadgets only for people who are interested in it. Different types of gadgets available. Old procedures do exist as well, which is like hypochlorous. I talked about the mesh, so this is for your own reference. The only thing I want to say, there's a lot of talk about ASIA syndromes or autoimmune disease to do with mesh. That's never been proven related with polypropylene mesh, and continue not to be proven. And my fellow and I, back in 2019, we did a systematic review looking into every single mesh procedures done since the existence of mesh. The ASIA syndromes or the autoimmune is dedicated for the silicone used in the breast implants, not for the mesh, but people in the public and in the media try to put it exactly as the mesh. Still has not been proved, and we reviewed over 6,000 studies, and not one of them has actually have used the reference to it. And having colonoscopy versus having a polypropylene mesh has no difference in terms of your immune system. Sorry, there's a lot of things to talk for 20 minutes. Apologies. There are some cases for your interest afterwards if you want to have a look, and if you have any questions, please let me know.
So thank you very very much, Dr. Salwan, for this very lovely talk. I'm sure you would have loved to listen to most of it. Can I ask our speakers, please, to come here? If you can sit there, please. And the floor is open for questions. We have 15 minutes if anybody would love to ask any question.
Still, questions to media about the HRT, the breast. So the progesterone you're using to protect the breast or
Progesterone to protect the uterus from proliferation and hyperplasia and cancer. So if the woman has a uterus and you put her on replacement therapy, she should be on both estrogen and progesterone. The estrogen is to control her symptoms, and the progesterone mainly is to prevent endometrial proliferation. So that is a must to be used in women who have a uterus.
So my question is that the HRT,
The other one for
the person said they don't recommend it at all because of the high risk of stimulating breast. I just would like to know how safe that we said 1 in 2,000 cases. Any more or less to give us more assurance that we will survive HRT, we're not going to even one case if of cancer. It will be devastating to
So in women with breast cancer, and if their breast cancer is ER positive, so they have receptors of estrogen and progesterone in their breast cancer diagnosis, those ones I won't put them on hormone replacement therapy unless I consult the breast surgeon. Because if they do have receptor positive, then they should not be on any hormone replacement therapy. That is a very different identity. We're talking about women with no history of breast cancer and they require hormone replacement therapy.
even if it's a family?
Even if there's a family history, as long as there's no personal history of breast cancer, then the risk will increase by 1 in 1,000 if they use it for more than 5 years. But if there's personal history of breast cancer, I won't put them on hormone replacement therapy without consulting with their breast surgeon.
Can I please ask to present yourself before the question, please?
My name is Dr. Omar Wafik. I'm a GP from Abingdon, Melbourne. A question about fibroids. Do we need any follow-up for fibroids? And another question to Dr. Media too. You said menopause is 12 months of no periods. As far as I know, it's 2 years if you're under 50 years of age and 1 year if you are over 50 years of age. Is that right?
By definition, as far as I am aware and known, it's 12 months from cessation of the last period.
Thank you.
What did you ask, sorry, about the fibroid?
Fibroids, do we need any follow-up? Do they ever change to malignants? Do we have to do some follow-up?
So they don't, benign fibroids, they don't change to malignant, but sarcomas can look like a fibroid. Therefore, if you find someone with unusual presentation with suddenly growing mass or a new finding of a sort of enlarging uterus, heavy bleeding, it's recommended that you actually follow it up to confirm that the mass is not rapidly growing or not changing in appearance to make sure that there is no underlying cancer.
So how long before?
I will recommend like anything between 6 to 8 weeks follow-up or about 2 to 3 months, like after the first ultrasound.
Okay. Thank you.
Sorry, just to read about one of bariatric was also breast surgeons. Going to media, I've been asked a lot. I like HRT because a woman will go on yearly ultrasound and mammogram, so that will increase the pre-detections. So it's only when you treat this disease of breast, then we have to discuss it further about HRT. But it's very safe. Don't be afraid using it, provided you're going to counsel your patient that they're going to have yearly mammogram and ultrasound. So family history is not very important. Thank you.
أحمد الرباعي. سؤالي للدكتور سلوان. طبعا ممتنين احنا لكل البرزنترز والبرزنتيشن كانت رائعه. دكتور سلوان احنا عندنا بالجاسترونترولوجي cases of chronic or idiopathic constipation where when we do the nuclear study, the cause is not in the colonic dysmotility or inertia. The cause is what we call it obstructive defecation, which is pelvic floor dysfunction or sphincter dysfunction. Now, for those, we recommend pelvic floor exercise and biofeedback. But our at least what data indicate this is not very effective. How effective these techniques in cases of urodynamic failure?
Very good question. The specific obstructive defecations in relation to it's a very kind of extensive subject. One of them actually is, for example, I saw patients who's never had been pregnant before and never had a vaginal birth, and they have a posterior vaginal wall prolapse. Displayed by obstructive defecation. So it started as a constipation, later bowel syndromes, and maybe to chronic constipations, and then they developed like they have lacking of supportive tissue in the back wall of the vagina. Obstructive defecations, when it is very well diagnosed by like MRI proctograms or with the existence of a rectocele, which is the posterior vaginal wall prolapse, and get corrected, they have fantastic results surgically. Especially when it's combined with physical examinations and suggested that this is a rectocele. When there is no rectocele and they have obstructive defecations, it becomes a bit of a tug war between the gastroenterologist and the urogynecologist, because we say it's not our problems and they say it's not our problem. But in the existence of a rectocele, as well as a proof of having obstructive defecations in the last 7 to 10 centimeters of the gastrointestinal tract, the effect of the surgery to correct the prolapse is very, very effective. I didn't find the pelvic floor exercise very effective.
So just going back to the fibroids, is there anybody in doing LDH? Like I see some specialists, like when they detect fibroids, they do lactate dehydrogenase. Anybody doing that?
No. I will not recommend doing any tumor markers if you are not concerned about cancer, because they can get they're elevated in many other conditions, and it creates a lot of confusion. If you are concerned, refer them to the gynecologist. They will work them up, and they will decide which tumor markers to organize.
And you said you leave about 6 to 8 weeks interval between the first scan and the second
If
scan.
a patient presenting with menorrhagia, you send them for a scan, they have a new findings, I will repeat the scan to confirm that these are not progressive findings.
And if after 6 weeks
I will leave a little bit, it depends what the symptoms. I will leave more towards 8 to 12 weeks for fibroids and assess again.
And if that scan comes not showing any changes, that's it.
Then
There's
that's
no
it.
need for
Yeah,
any
but you will
further
need to
follow-up.
address their symptoms and find exactly what's going on. So if it's heavy bleeding, address that. If it's pressure symptoms, address that. If they have a big uterus that's causing pressure on the bladder, causing problem with the bowel, I will address all of that. Pain.
Sure, thank you.
Mohammed Jaiba, upper GI surgeon, Wollongong. Thank you for the panel. Very nice and informative session. 2 questions, one to Juman. In terms of management of the fibroid, is there any update or a role related to CT-guided embolization of the main or part of the branch of the uterine artery? And the second question to the panel, we do receive lots of referrals about liver adenomas, which is ideally in young ladies being on OCPs for more than 10 years, and whether we resect or not, they have to stop any estrogen-containing modality. If they're still interested in more contraception and not willing to go into the male ways of contraception, is there any way to advise them about that? Thanks.
So for CT, it's sort of embolization of the vessels for the fibroids. It's a very well-known procedure, and the downside of it is that it should be done for women who do not seek fertility anymore. So a lot of the fibroid presentations are for women who are still willing to have their fertility option preserved, and it's not recommended in that setting. If a woman chose to proceed with ligatoric embolization of the vessels, that's a very reasonable option. They just need to aware that there is a risk of failure and they might need a hysterectomy eventually. It shrinks the fibroid, so it's very suitable for women who are perimenopausal. I can answer you about the question about the pill. You can use alternatives like the IUD marina progesterone, which doesn't have estrogen. Am I right?
I was going to add also other progesterone-only contraception, like Depo-Provera injections 3 monthly, or the pills, progesterone-only pills, either macrolide or Splenda. So there are multiple options for progesterone-only. For copper IUD, they don't want any hormone at all, so there is no medication.
Wafan Omari. My question to Dr. Iman. Very nice presentation. I would like to have your opinion about the use of Visan in endometriosis, the medication.
Yes, I frequently use it, as I said, after excision of endometriosis. I put the Mirena in as a first because it works locally, progesterone, and it's very effective. After 3 to 6 months, they still symptoms are still bothersome, so I will add Visan. I ask them to come back in 3 to 6 months, and if its symptoms are controlled, then I'll continue on the Visan and Mirena in situ, like 2 agents. And I'll continue like that for a long time.
Classic dose, 2 milligrams.
2 milligrams, yeah, 2 milligrams. And the Zoladex as a last resort, yeah.